I'm hoping that we're all going to find this an interesting point of discussion, and I'm very privileged to the ESPR for their kind invitation to speak at this meeting. My declarations, I declare that I am the Chief Investigator of a clinical trial about which I'm going to speak briefly in my talk, and that the method that we're using for delivering surfactant is an off-label use of surfactant at the moment, and that in the trial that I'm going to speak about, Chiesi are supplying the surfactant for the study. And I'm also going to declare that I'm from a very hostile place. And for those of you who know Australia, you'd know that all that is true. But you'd also be aware that down the bottom of Australia there's this beautiful island, this jewel in the crown called Tasmania, and that's where I'm from. And here are the attributes of Tasmania that I'd like to share with you. This is a wonderful place to visit, so I would very much welcome any of you to come, and please let me know if you do. So we'd like to share with you today some thoughts about minimally invasive surfactant therapy. And I'd like to start by talking through the CPAP surfactant dilemma, by talking about some of the methods of minimally invasive surfactant therapy and introducing the methods that Angela and Jane will then further elucidate. I want to focus particularly on the methods of tracheal catheterisation that are now in use, and to talk a little bit about the future and the challenges that we face. So let's start here with what I can see is a very important group of studies that I think we're all very aware of and need to take great note of. The COIN trial, published in 2008, Support 2010, and the VON or DRM study, published in 2011. Each of these studies compared the use of initial CPAP with intubation in very preterm infants who ranged between 23 and 29 weeks, although not all studies used all gestation ranges. Two of the studies mandated the use of surfactant after intubation in that group, and that's the Support and the VON study. The COIN study did not mandate surfactant, but it was given to the majority of infants, 77%, after intubation in that arm of the study. And I've done a meta-analysis of these three studies, in particular looking at the outcome of death or chronic lung disease, death or BPD, bronchopulmonary dysplasia, an oxygen requirement at 36 weeks gestation. And we can see that although each of these studies individually did not show a significant benefit in favour of the CPAP arm, when grouped together as they are here, we can see that there is a significant benefit with our diamond on the forest plot, not impacting on the line of unity, and in this case a risk ratio of 0.88 and a number needed to treat of around 20 infants. So the potential there for a significant benefit of CPAP over intubation in our smallest preterm infants. And if we use that as our starting point, the acceptance that CPAP might be a reasonably good, potentially a better approach than intubation in our smallest babies. I then want to just talk through what happens when we apply CPAP at the beginning, because if you apply CPAP at the beginning, the baby's not intubated at the beginning. And if the baby's not intubated, that means surfactant is either not given or is given at a delayed time. And so I'm going to put to you that applying CPAP to a group of unselected babies at the beginning of life means that some who have significant RDS will go undertreated. And that to us is a big concern. And as you'll see in the randomised controlled trials, each of them showed that even though babies with CPAP ultimately appeared to get some benefit from it, in those first days of life, many of those who started on CPAP went on to be intubated. And you can see there the percentages in the COIN trial, 46% in the first 5 days, in the support study around 70%, and in the VON DRM study around 45% intubated in the first days of life. We've analysed this in our own data set from the Australian and New Zealand Neonatal Network, and we're working on data for the years beyond 2007, but I'm going to present some data from 2007 that we've previously presented at national and international meetings. And we had a group of 1,007 infants in the gestation range 25 to 28 weeks that we studied. And unsurprisingly, when we examine the outcomes for babies who A, started on by being intubated, or B, started by being placed on CPAP, we can see that their paths did diverge a little, but remember, this is not in any way a controlled study. This is just an observational study, and certainly the babies who started on CPAP are a little bit more mature in gestation, in better condition at birth, and had a whole lot of things in their favour. And we can certainly see, if we take the example of death or BPD, a considerable difference in the risk of that outcome, depending on what mode of respiratory support was used at the start. But now I'm going to put to you that maybe within this group of babies who started on CPAP, there are actually two subgroups. There's those who have pretty good lungs, reasonably mature lungs, and are destined to be able to be well supported by CPAP. And then there are a group who have significant RDS, surfactant deficiency, which might creep up on them over the course of the hours after birth and get them into real trouble and ultimately lead them to failing CPAP. And so we looked at that by dividing up the CPAP group into those babies who failed and required intubation in the first 72 hours and those that succeeded. And it's very interesting because their paths really diverge at this point. And you can see that having failed CPAP in the first 72 hours, the risk of adverse outcomes are very significant, and perhaps even more surprising and interesting, alarming, is that their outcomes aren't much better than those who are intubated at the start. So this does raise a very important point that within the whole unselected population of babies we might choose to start on CPAP, there's a subgroup who might need more than CPAP. And I would propose that what they need potentially is a dose of surfactant. So perhaps the risk reduction that we see with CPAP versus intubation as it is now, if we could do something more for that subgroup that are failing, we could move that relative risk really well to the left and be showing much more of a benefit. So why do babies fail CPAP? Well, our own data from a 2-hospital cohort study published in Neonatology this year tells us that the vast majority of babies who fail CPAP do so because they have significant RDS. And for the 25 to 28 week group, 93% of that group who failed CPAP had either moderate or severe RDS on the CARO radiological scoring system. There are animal data also in support of this notion that the amount of surfactant determines how well you would cope on CPAP. A study from Alan Job's group looking at the amount of saturated phosphatidylcholine, the main surface active phospholipid in the bronchoalveolar lavage fluid of preterm lambs that were started on CPAP. This was CPAP delivered via an endotracheal tube. And there were a group who were successful on CPAP, and they had a good amount of saturated phosphatidylcholine in their bronchoalveolar lavage fluid. They were destined to succeed and be able to keep their lungs well expanded and keep their tidal volumes adequate. On the other hand, there were a group that failed and needed to go on to full positive pressure ventilation, and those lambs clearly were deficient in surfactant. So there are good data in support of this notion that the reason why babies fail CPAP is because they don't have enough surfactant. So there is a dilemma here. Should we use surfactant? Should we use CPAP? Or, even better, should we try and do both? So how can we give surfactant to babies who are on CPAP? And you'll all be well familiar with the concept of inshore, where endotracheal tube is briefly inserted, the surfactant's given, and the hope is then to be able to remove the tube. And I've put down those two disadvantages there of Insure, that there, in many, if not most units, would be considered to be the need for sedation to pass an endotracheal tube through the vocal cords, and perhaps more importantly in the longer term is the fact that it's difficult to pull the tube out sometimes. In the CURPAP study, where the primary outcome was the need for mechanical ventilation at 5 days, there wasn't a difference in the outcome in the two comparator groups, one starting on nasal CPAP, one getting Insure and prophylactic surfactant. And the reason for that was because in many cases, when the prophylactic surfactant had been given, the tube stayed in. And so this highlights the difficulty of using Insure, particularly as it was here, used in an unselected population, in achieving any benefit over starting on CPAP. So let's then move beyond that and just suppose that perhaps the best thing to do is come up with something that's less invasive. And the term minimally invasive surfactant therapy is intended to mean it's as minimally invasive as possible. And I think you'll agree that some of the methods I'm going to show you are still somewhat invasive, and we accept that. But the concept is that we deliver surfactant to a spontaneously breathing baby who can then continue on CPAP and is now surfactant replete where they were surfactant deplete. So there are a number of methods that have been described. John Catwinkle rediscovered an old method of giving surfactant into the pharynx, which was first described in the early placebo-controlled surfactant trials, and he described a method in 2004 of nasopharyngeal installation of surfactant. And here's what he described was done in the delivery room. He said that as soon as the baby's head appeared on the perineum, the mother was instructed to stop pushing. The neonatologist then instilled the surfactant into the posterior pharynx. The CPAP was then administered by mask as the shoulders were delivered, and the baby was stimulated to initiate spontaneous respiration. And whilst I think this is an interesting notion to pursue in a research setting, I think most of you would agree this is potentially impractical in most of our units and in most of our settings. Laryngeal mask installation of surfactant has certainly been described in a number of papers, and Trevor Sanuto's group have done quite a little bit of work on this. The difficulties here are that not so many people are really familiar with the use of laryngeal masks, and additionally they're not able to be easily inserted into the hypopharynx in babies much below 27, 28 weeks. So I'm not going to mention this method anymore. We are fortunate in having Jane Pillow as a speaker in this session to tell us all about aerosolisation. And I think we can all accept that this is easily potentially the least invasive method of giving surfactant to babies who are on CPAP, and Jane's going to spend quite some time telling us about her experiences there. We're also familiar with the fact that there are now methods whereby the trachea is briefly catheterised with a thin catheter to administer surfactant, and I'm going to spend a little bit of time talking about those methods. The one that's perhaps most familiar to all of us is that was rediscovered by Angela Cribbs in 2007 of using a gastric tube or feeding tube inserted through the vocal cords with McGill forceps. And she rediscovered a method that Hendrik Werder had originally described back in 1992 in the Danish literature, and which was then subsequently abandoned as intubation became much the routine. And so the method does involve the use of McGill's forceps to get the feeding tube through, because the feeding tube's relatively flexible and floppy and not that easy to get through the vocal cords. The mode of surfactant delivery using this technique is by a slow push. Angela, who's our next speaker, will give us much more information about her experience of this technique and about the trials that have been done using this approach. We took the view that it would be better to have a method, or potentially better for some units, to have a method that didn't involve McGill's forceps, and have developed a method that involves the use of an angiocath, a semi-rigid catheter, which can be passed through the vocal cords without McGill's forceps. In our case, for this Hobart method, we use our surfactant delivery as a bolus in 3 to 4 boluses over about 15 to 30 seconds and do not use any pre-medication other than sucrose administered into the oropharynx. A further method that's been now published is by a group from Ankara in Turkey using a 5 French feeding tube which is cut down and with their great skill is inserted into the trachea through the vocal cords without using McGill's forceps, which I still find in concept a great challenge. Their surfactant is administered via a slow bolus, 30 to 60 seconds, and no pre-medication is used. And the method that's used by the team at Karolinska, with Kaiser as the chief investigator, is one where a 5 French catheter, which is quite long, longer than any of the other catheters, is passed through the vocal cords. McGill's forceps not necessary. The surfactant delivered as a slow bolus. In the case of the Karolinska group, sedation has been used, and this is one of the important questions that needs to be addressed as we pursue this mode of treatment in our preterm infants. I'm just going to show you the Hobart method, which uses this semi-rigid catheter, which is about half the external diameter of a 2.5mm ETT. And hopefully our video will show us this technique. Before I start, we'll see that this baby, who's 27 weeks and 1 kilo, has Hudson prongs in situ, and so the CPAP is continuing to be applied and extra oxygen continuing to be given for most of the procedure that's to follow. And we also see that the laryngoscope, which is a standard laryngoscope, is already in place. There's the catheter going through with a little hook on the end, which we can fashion if wanted. In this case, a pretty easy catheterisation of the trachea. You'll see the baby move and breathe a little bit during this procedure. The surfactant syringe is there hooked up. In this case, the dose that's used is 200 milligrams per kilo of Curasurf, and you'll see it given in 3 boluses. Third bolus just about to go in. You can see a little bit of the surfactants effluxing into the mouth. You can also see the baby's now back on CPAP and ready to start the next part of the journey, except now the baby has a dose of surfactant in the lungs, where before there was not sufficient surfactant. As I mentioned, one of the key issues for us all is with the tracheal catheterisation approach, we're using a normal laryngoscope. We know that there's potential for discomfort with laryngoscopy. Each of the methods described uses laryngoscopy. We need to work out whether we can improve upon these methods, and also we need to be sure that it's appropriate to do it with sedation if we feel we need to do that, or without sedation. And so there definitely need to be studies that look very carefully at the adverse effects of performing the procedure and also any long-term differences in babies in groups that have and have not had the procedure. There have been a few completed trials, and Angela will tell us about the AMV trial and also about the recently completed NINZAP study. The things I want to point out, these are all trials of tracheal catheterisation. The things to know are, first of all, that in each of the studies there are about 100 babies in each of the comparator groups. So these are not very large studies and not powered necessarily to detect differences, small differences in important outcomes that we might want to know about. Secondly, each of the trials looked at a method of giving surfactant into the trachea by catheterisation, but the comparator group in each case was different. For example, in the AMV trial, the comparator group was continuation on CPAP. In the Take Care study, the comparator group was with Insure, giving the same dose of surfactant into the trachea, except using an endotracheal tube and positive pressure ventilation rather than a thin catheter and spontaneous breathing. And the third study, which we'll hear about today, was a study comparing Lisa using the Cologne method with intubation, ventilation and surfactant therapy. Each of the studies had a different gestation range. The studies also had somewhat different entry criteria. And you can see I'm pointing here to the heterogeneity of these studies and the difficulty that we have currently really interpreting the data that are available. So as you can imagine, at the end, I'm certainly going to point to the need to do more studies and more clinical trials so that we can better understand this technique. I am going to mention the Turkish study for a couple of reasons. This was a study, as we know, of putting a thin catheter in the vocal cords without using Magill's forceps, done by a team in one hospital in Ankara. And they looked at the primary outcome of any early mechanical ventilation and also any mechanical ventilation. And here's the take care group, spontaneous breathing. Here's the insure group, positive pressure ventilation. And somewhat surprisingly, given the fact that the same dose of surfactant is going into the trachea at the same sort of time, there was a considerable difference in outcome, with a reduction in early mechanical ventilation, a trend towards a reduction in any mechanical ventilation, and a significant difference in the rate of BPD oxygen requirement at 36 weeks gestation. And there were also, in the subgroup of babies at or below 28 weeks, there are similar findings. The Take Care team brought themselves to conclude that while their study findings were very interesting, they felt that further studies concerning the effect on BPD with sufficient power would be needed. And they also drew attention to this very important and interesting idea that maybe spontaneous breathing makes a difference to where the surfactant goes and how effective it is. And so they say that giving manual inflations to re-expand the lungs and facilitate surfactant spreading may actually result in more uneven surfactant distribution than during spontaneous breathing. And I'll take this theme up again shortly. There are some ongoing and planned studies. I'm the chief investigator, as I said, of the Optimist A trial, and our intervention here is LISA, less invasive surfactant administration using the Hobart method, and our comparator group is CPAP, continuation of CPAP. Study entry is at a FiO2 of 0.3 or above, and the gestation range we're studying is 25 to 28 weeks. Kaiser and her colleagues in the Karolinska are planning the SAINT trial, which has not yet got underway. Here the intervention group is LISA with the Karolinska method versus Inshore as the comparator group in babies less than 32 weeks gestation, and the criteria for entry are based on AA ratios. And there are a couple of other studies that I'm not going to talk about any further where there's a clinicaltrials.gov entry, but I don't think much more infrastructure or impetus to begin as yet. I'll just briefly mention the feasibility study that has led us to want to pursue this therapy in the Optimist A trial. And we published these data this year in the archives. The group that we studied were babies 25 to 32 weeks. And these babies were quite sick with RDS, with a CPAP pressure of at least 7, oxygen requirement of 30 or 35%. And the important thing here was we had 15 different neonatologists who were competent at standard intubation, able to do this procedure. The intervention was done relatively early in the 25 to 28 week babies. We did see some bradycardia in some cases, and I think it's going to be very important to document these outcomes. We found, as we got more used to the technique, keeping the Hudson prongs in place as the laryngoscopy was being done certainly helped reduce the likelihood of bradycardia and the duration of bradycardia, and also to maintain the saturations. Because we initially would take the CPAP off, we did need to use positive pressure inflations by mask in almost half of the 25 to 28 week babies. But as I said, as we got more familiar with using Hudson prongs and keeping them in place, we found we need to do this less. Importantly, the procedure was able to be completed relatively quickly. in around 2 minutes in both the gestation ranges. And very importantly and interestingly, the response in terms of the reduction in FiO2 is rapid, because it's started to happen and really got going in half an hour. It's profound, because it's a reduction down to 25% oxygen from, as you can see, a starting point above 40%. And perhaps even most importantly, it's sustained, which means that this exogenous surfactant that we are supplying to this baby is able to be incorporated into the total surfactant pool and become part of the endogenous surfactant that keeps getting resecreted over and over again. As adults, we turn over our whole surfactant pool in 10 hours. Babies turn over their surfactant pool very quickly, particularly when they don't start with much. So getting this exogenous surfactant to be taken into the cells is critical, and there was good evidence for that in these babies who were able to sustain low FiO2. Some of the babies of the starting group got intubated later on, but as you can see, most of them were able to stay off ventilation. We had evidence of benefits or potential benefits from this feasibility study that made us wish to pursue this therapy. And we compared our treated group with a group of historical controls who had achieved the same CPAP and FiO2 thresholds. And we saw, particularly for the 25 to 28 week babies, a reduction in the proportion requiring intubation less than 72 hours and a significant drop in their days in oxygen. So I'm just going to now briefly mention a little bit about the Optimus Day study. The trial question here is whether the administration of exogenous surfactant using a minimally invasive method might improve outcome in preterm infants in the 25 to 28 week range who have started life on CPAP. We're looking for inborn infants in that gestation range. They need to be on CPAP or, as an alternative, NIPPV with an FiO2 that's reached 30% at an age less than 6 hours, and we would exclude babies where we felt that there was an imminent need for intubation, an alternative cause for respiratory distress, or a congenital anomaly that might affect breathing. The randomisation for our study is via a web-based randomisation system, and it divides the groups into those randomised to receive surfactant and those who are going to be controls continuing on CPAP. We are stratifying by study centre and also by gestation. The intervention in the treated group is to receive surfactant via the Hobart method. A dose of 200 milligrams per kilo will be used and CPAP thereafter reinstituted. In the standard care group, these babies will continue on CPAP. The intervention is going to be masked from the clinicians, and we do that by getting a treatment team, clinicians not immediately involved in the clinical care for that infant, to do the randomisation and perform the intervention. And despite the challenges that this obviously presents in every unit, we've seen in the units that are now in the study that it can be done and that the blinding is effective for the clinicians that are looking after the babies. The post-intervention management in Optimus Day involves adherence to some criteria for intervention, which include an FiO2 of 0.45 or, by physician discretion, down to 0.4, unremitting apnea or persistent acidosis, and these criteria apply in the first week of life and only to the first episode of intubation. The other management are things that we would normally expect units to undertake: titration of CPAP pressure being encouraged, nasal IPPV allowable, and caffeine therapy expected. And we'll be doing a BPD assessment, so you'll see the primary outcome includes physiological BPD, and so we're doing, in babies that need to have it done, an air trial at 36 weeks gestation to ascertain whether they have BPD by that physiological definition of Walsh and co-workers. The primary outcome is the composite of death or physiological BPD, and the converse, obviously, is survival without BPD at 36 weeks gestation. Our sample size compared to the studies that are already in existence is relatively large. So we're looking for 606 infants with 303 in each group, giving us 90% power to detect a 33% reduction in the rate of the primary outcome from our anticipated rate in the control group of 38%. Why would we be doing this study? Why is it important to us to do it? Well, we clearly think it's evaluating an approach which is potentially the next logical step in refining the care we provide to preterm infants with ADS. And we do think it will give definitive information about the place of surfactant installation via brief tracheal catheterisation. And we don't think it's about one method of getting this surfactant into the trachea. We think that the information from the Optimus study would apply equally to different methods of catheterisation through the vocal cords. We have a large range of participating centres and centres that are interested. We're looking for more. This will be a truly multi-centre international study. It's a collaboration initially between the Australia-New Zealand network and the Vermont-Oxford network, but a lot of other units are interested in participating. If you're one of them, I'd very much like to know that, and you could come talk to me this afternoon, but also we're holding an information session on the Optimus Day study tomorrow morning in the PK room on the ground floor here. It starts at the rather unfortunate time of 7:30, but finishes at the much more genial time of 9 a.m. So if you come any time in between those two times, we might be able to have a coffee and some cakes and discuss the study. I'd like to conclude now just by talking through what we currently think about these methods that we've got to deliver surfactant using minimally invasive approaches. So if we think about the different approaches that I've indicated and their applicability, I think we can agree that tracheal catheterisation wins now at the moment in that sense, because it's a method that's been used in thousands of babies and has been shown to be very promising and is immediately available. In terms of being minimally invasive, clearly you'd have to think that aerosolisation wins the prize there. Oops. And potentially pharyngeal deposition is relatively minimally invasive, but we've seen the difficulties with the practicability of that technique. In single rapid dosing, the methods other than aerosolisation seem to be favoured. In effective distribution, we're guessing. And we're certainly guessing about aerosolisation, and I think that's an issue that really needs to be looked at very carefully because some studies, but not all, have shown that the distribution of surfactant with aerosolisation is a problem. Jane will tell you more about that. And I'm going to, in my final remarks, ask what do we need to do? And I certainly think that we need to identify the babies who are going to benefit from getting a dose of surfactant using a minimally invasive method when they're on CPAP, because not all babies on CPAP need it. We need more research on the techniques of tracheal catheterisation, the types of catheters, whether we can stop surfactant effluxing back, whether we should be using stiff catheters or feeding tubes. We need to know more about that. We need to understand the best mode of administration. Do we give it rapidly as a few boluses, or do we give it more slowly? We certainly need more understanding of what the effect of spontaneous breathing is. We need to gather more data on the side effects of tracheal catheterisation, because I think you can see that whilst it's less invasive perhaps than intubation, it's still performing a laryngoscopy. We definitely need to sort out the issue of sedation, and we need further trials that are adequately powered to compare longer-term outcomes, trials in more mature infants, and I haven't mentioned it, but we plan to do a trial in 29 to 32-week babies. That's the Optimus B trial, if we're funded to do so. We need trials in resource-poor settings where application of CPAP may be all that's on offer, and if they could make their babies have sufficient surfactant, that would be good, and trials in non-tertiary centres where giving surfactant this way may avoid a transfer. And we certainly need to pursue the least invasive methods, especially aerosolisation. So I'll finish there. I'll acknowledge the great work of the co-workers indicated here and also the funding bodies that have contributed so much to this work. Thank you very much.